Leah, can you hear me?
ma'am.
Okay, and screen slides okay. Can we start? Please, 70 participants.
Ma'am.
Okay. So today's class is on tear film and dry eye disorders. So first we will be covering what is tear film, how is it produced, how is it drained, then what are the tests to detect dry eye deficiency and what are the disorders. So first is actually about tear film. So precorneal tear film covers the cornea. It has 3 layers from posterior to anterior. It is mucus layer, then comes the aqueous layer, then the lipid layer. This is how the 3 layers are being arranged. The innermost is the mucus layer. Then that accounts to only around 0.1 micrometer. Then aqueous layer is around 7 to 10 microns, and mucinous layer or the lipid layer, which is the outermost layer, is the lipid layer, which is the outermost layer, is the constitutes around 0.1 meter, 0.1. The innermost layer is the mucinous layer, which accounts around 0.2 to 1 microns. Then we have the largest layer, which is the aqueous layer, which is around 7 to 10 microns, and the outermost layer is the lipid layer, which is only 0.1 microns. This is the structure. So this is the innermost layer, which is the mucus layer. Here we can see that this mucus layer is being secreted by the goblet cells, which is present in the conjunctiva. So the conjunctival goblet cells is responsible for secretion of the mucus layer, which is the innermost layer of the tear film. Then this bulky part, which is the aqueous layer, is mainly produced by the lacrimal gland. And the lipid layer, which is the outermost coating, which helps to retard evaporation of the aqueous layer, is being produced by the meibomian glands. This is how the meibomian gland is arranged. It is known as a piano key pattern. Then these are the 3 layers. The mucin layer, which is the innermost and the thinnest layer, is the mucin layer. It is secreted by conjunctival goblet cells and also glands of Mans. And the function of mucin layer is it converts the hydrophobic corneal surface to hydrophilic. Aqueous layer is actually the intermediate layer. It forms bulk of tear film. It is secreted by main and accessory lacrimal gland. And the constituency of tear film is mainly water, sodium chloride, urea. And also we have antibacterials like lysozyme and beta-lysine. The outermost layer is the lipid layer or the oily layer. It forms actually the air-tear interface. Then atmosphere contact layer lipid layer. It is secreted by meibomian gland. Also, C's gland and mole glands also contribute to its secretion. The main function is it prevents overflow of tears, retards the evaporation, and also lubricate the eyelids. So these are the 3 important layers. This is actually to show the function of the mucin layer. What happens is actually this is The red color is the mucin. So it aids in wetting the corneal epithelium. So we need a normal amount of mucin, then only the epithelium will be properly wetted. But in cases of mucin deficiency, we can see that the aqueous layer, which is seen as a blue color, it's not able to wet the corneal epithelium. This is the corneal epithelial cell. This is the aqueous layer. Due to mucin deficiency, it is not able to make the cornea wet. Only when a sufficient amount of mucin is present, the cornea will be converted from a hydrophobic state to a hydrophilic state. So again, these are the three layers. For once more, mucin layer, it adheres tears to the eye. Aqueous layer nourishes and protects the cornea, and the lipid layer lubricates and prevents the evaporation. The Meibomian gland is responsible for the lipid layer secretion. So what are the functions of tear film? One is it moistens cornea and conjunctiva. Why is tear film important actually? This is very important because the most common problem that we encounter daily in OPD is a problem with the dry eyes. So it moistens cornea and conjunctiva. The another thing is in physiology, you have learned that it provides oxygen to corneal epithelium. So normal tear film is very important for that, and washes away debris and noxious irritants. Also, it is antibacterial, so it prevents infection, and it also facilitates the movement of lid over globe. Now, tear is secreted mainly throughout the day by lacrimal glands. So we have accessory lacrimal glands and also main lacrimal glands. We have two types of secretion. One is a basal secretion and the other one is a reflex secretion. Basal secretion means it is the tear is also produced while we are resting. So that is the basal secretion. It is mainly by the accessory glands. Reflex secretion means in response to some reflex, like in an injury or in some cases when we are having any exposure to irritants, wind, something like that. So that is mainly by the main lacrimal glands. So why these two important? Important means Schirmer's test helps in differentiating these two types of secretions. One is basal secretion, which is maintained by accessory glands. This is a resting secretion, and the main lacrimal glands is responsible for the reflex secretion. Okay, then when there is when does hyperlacrimation occur? When there is any irritation from cornea and conjunctiva. What is the afferent of this? That is when there is a sensation only we'll have this reflex secretion. No? So what is the which is the nerve which is responsible for producing sensations? The afferent is fifth nerve. Over the face, the cornea, everything is trigeminal nerve, the fifth nerve, and the efferent is actually parasympathetic, or the secretomotor fibers are responsible for reflex secretion. So this is again the same thing. Lacrimal glands. We have accessory glands, which is responsible for basic or the resting secretion. Then the reflex secretion is mainly by the accessory glands. And the problem? Am I audible?
Yes, ma'am.
Okay. Reflex secretion is reduced by topical anesthesia and sleep. That means only when we are able to, when we are able to have a stimulation, there will be reflex secretion. So when we are applying a topical anesthesia, this sensation will be lost. So in that case, actually what happens is this reflex secretion will be reduced. And I've already told that in injury, this reflex secretion will be increased around by 500%. That's the difference. Okay, so the elimination of tears. How is tears being drained? The tears are being drained, or it flows downward and medially. It is produced by the lacrimal glands. Then it flows downwards and medially across the surface of eyeball to reach the lower fornix, and from there to the inner canthus, and it reaches the lacrimal passages, from there to the nasal cavity. This is actually the lacrimal apparatus part. So active lacrimal pump mechanism is constituted by the fibers of orbicularis, which is inserted on the lacrimal sac. So what happens is when we are blinking, the lids are being closed. When the lids are being closed, which fibers are contracting? The orbicularis oculi muscles are being contracted. So that causes distension of the fundus of lacrimal sac. That will create a negative pressure. So due to this negative pressure, the tear will be flowing through the punctum and canaliculi into the sac. So this is actually the passages. Here, this is how it is being produced from the lacrimal gland through the lacrimal duct. It comes to the fornix. From the fornix, that enters the punctum. From the punctum, then enters the inferior and the superior canaliculi or joins the common canaliculi, opens into the lacrimal sac, and from there it goes to the nasolacrimal duct and opens into the nasal cavity. So this is what is happening when we are closing the eyelids. So the eyelids have, the tear film have reached here. So when we are closing the lids, the orbicularis muscle is being contracted. So that creates a negative pressure. So that causes the tear film to get drained into the lacrimal sac. So that enters the lacrimal sac, and when we open the eye, it is getting drained to the nasal cavity. So what is the difference between xerophthalmia and cirrhosis? Cirrhosis means any type of ocular dryness. We give a name as cirrhosis. Xerophthalmia is a dry eye which is specifically associated with vitamin A deficiency. So vitamin A deficiency is one of the causes for dry eyes. So when a dry eye which is associated or which is due to vitamin A deficiency, we call it a xerophthalmia. But cirrhosis means an extreme ocular dryness and keratinization that occurs in eyes with severe conjunctival cicatrization. So any causes, we can call it as a cirrhosis. It is the main name is actually keratoconjunctivitis sicca. That means any refers to any eye with some degree of dryness. So a smooth, stable, and rewettable ocular surface is essential for good vision and comfort. So what are the causes for dry eye? One is actually due to reduced tear production, or it may be due to an excessive tear evaporation. So what happens is the tear film will be unstable and there will be an ocular surface disorder. So the patient will complain of the patient's quality of life will be reduced. And many patients come to OPD with complaints of irritation, burning sensation, watering from the eyes due to dryness. Okay, so what is dry eye? It is a symptom complex due to deficiency or abnormality of tear film. Actually, what is happening? Two causes I already mentioned. One is actually due to reduced production of tears. So what may be the causes for reduced production of tears or reduced secretion? The tears are mainly produced from the lacrimal gland. So it may be due to a lacrimal gland disease, or the reflex secretion is mainly due to corneal sensation. So it can also occur in conditions when the corneal sensation is reduced. So these two conditions results in reduced secretion. Also, the tear film, even though the production is normal, increased evaporation can also result in dry eye disease. So the layer which is responsible for retarding the evaporation of dry eye is actually the outermost layer, the lipid layer, which is secreted by the meibomian gland. So any meibomian gland disease can also result in an increased evaporation. Also, the increased palpebral fissure width, like in cases the patient is having proptosis, like that condition, also the patient will be having a predisposition for dry eye. So these conditions will result in an increase in tear osmolarity. So this is the classification. That is, we can classify it into mainly aqueous deficiency and evaporative deficiency. So aqueous deficiency, I've already told that aqueous is mainly secreted by, aqueous layer is secreted by the lacrimal gland. So when there is any disorder affecting the lacrimal gland, it can produce a deficiency of the aqueous layer. So what is Sjogren's syndrome? It is an autoimmune condition which causes destruction of the lacrimal gland and the salivary gland. So the patient will be having symptoms of dry eyes and dry mouth. So in Sjogren's syndrome, we have aqueous deficiency because it affects the lacrimal gland. Two types are there, primary and secondary. The difference is Sjogren's syndrome primary means there is no other association. Secondary means in conditions with which is associated with other autoimmune disorders like rheumatoid arthritis, lupus. In such conditions, the patients can have Sjogren's syndrome in addition. So that is secondary. Now, what are the causes for non-Sjogren's type of aqueous deficiency? It may be due to another lacrimal gland problem, a lacrimal deficiency, lacrimal gland duct obstruction, a reflex block, or a systemic drugs. We'll be coming with, into the details later. And evaporative is actually, I'm already told that it is mainly by the lipid layer. So mainly the meibomian gland is responsible for that layer, production of that layer. So we have intrinsic factors as well as extrinsic factors. Intrinsic factors means within the eyelid itself, the meibomian oil deficiency or the disorders of the lid aperture or the low blink rate or the certain drugs like can also result in this type of dry eyes. And extrinsic is actually mainly from the vitamin A deficiency or the topical drug preservatives. Even the lubricants that we preserve for dry eye contain preservatives that itself can act as that itself can produce dry eye due to this thing. Then the contact lens wear is another important cause, and ocular surface disorder. So what is aqueous tear deficiency or keratoconjunctivitis sicca? That is mainly seen in congenital, one condition is congenital lacrimia, that is congenital absence of lacrimal gland. So that aqueous layer is not being produced. And the other conditions we have already seen, one is primary and secondary Sjogren syndrome, and also in Relay syndrome. Now, coming to reflex hyposecretion, we have come to, then we have mentioned about non-Sjogrens. Now, non-Sjogrens, we mentioned about the lacrimal gland deficiency, the lacrimal gland duct obstruction, and the reflex block. So we are coming to that, the reflex hyposecretion. What is that actually? It occurs when there is some problem with the sensations. Okay, the sensations will be reduced in conditions like when the patient is wearing contact lens, or in conditions like diabetes, or when the patient has undergone some refractive surgery, or in neurotrophic keratitis. These are the conditions when there is the reflex or the corneal sensation will be reduced in such conditions. So when the corneal sensation is reduced, you know that the afferent is the trigeminal nerve. So the reflex secretion is not working. So again, there will be deficiency of tears. And the motor component is actually, we know that the blink, everything is by the facial nerve. So seventh nerve damage is another cause. And then another cause is systemic drugs. So we'll be seeing which are the drugs which causes. Before that, what are the causes for decreased corneal sensation? Already mentioned a few causes. One is neurotrophic keratitis due to damage to the fifth nerve, corneal surgeries, any corneal surgeries actually, even cataract surgery patients after surgery will come and complain of dry eyes. So any surgeries which affect the or which destroys the normal ocular flora and all will result in this dry eye later. So corneal surgery, limbal incisions, keratoplasty, radial keratotomy, excimer laser surgery, then viral infections, that is herpes simplex virus, herpes zoster, ophthalmicus, and certain topical medications like beta blockers, atropine. This is one systemic condition which causes decreased corneal sensation is diabetes. And in young patients, when a young patient comes with a dry eye, you have to always roll out the history of contact lens wear. And always it increases with the increase in age. So aging is another important cause, and chronic ocular surface inflammation can also result in this condition. Okay. So actually, I haven't put a slide on this. What causes mucin deficiency? Mucin is mainly produced by goblet cells, conjunctival goblet cells. We have seen that the innermost layer is the mucin layer, that is by the conjunctival goblet cells. So any damage to goblet cells will result in mucin deficiency. So goblet cells, you know that actually the damage to goblet cells may be seen in all these conditions. The conjunctival, actually vitamin A deficiency. Vitamin A deficiency, the term is ophthalmia. Then we have Stevens-Johnson syndrome, trachoma, chemical burns, radiation, ocular pemphigoid. In all these conditions, we have mucin deficiencies also. Now, this is lipid deficiency. Lipid deficiency, we have already seen it is mainly produced by the meibomian gland. So meibomian gland problems will result in lipid deficiency. So congenital anhydrotic ectodermal dysplasia with absence of meibomian gland. At least you should know that when there is some problem with meibomian gland, there is lipid deficiency. So what are the conditions which affect our lid and having inflammatory conditions? Common conditions we see is chronic blepharitis, chronic meibomitis. All these patients will be coming and saying burning sensation, irritation. All these are because of the lipid deficiencies. And also in conditions of impaired lid function, like in Bell's palsy, exposure. Bell's palsy, you know that there will be inadequate lid closure in that condition. So what happens? The lids will be opened, and that causes an increased evaporation of the tear film. So that will result in exposure keratitis. Then another important is symplectron. Pterygium also is another important cause. And also ectropion. Ectropion is the outward rolling of the lid margin. So the tear will not stay. Again, there will be increased evaporation. And also in epitheliopathies, when the corneal epithelium is altered. So these are the causes. One is intrinsic is actually meibomian gland deficiency. That is posterior blepharitis, rosacea, in such type of condition. At least you should say meibomian gland deficiency. Then disorders of lid aperture, when there is an excessive scleral show, when there is a lid retraction, when there is proptosis, when there is a facial palsy. So the two important things you should remember here is one is proptosis and the second one is Bell's palsy. These are two conditions are very important. And when the blink rate is reduced also, there will be evaporative dry eye. Usually it is seen in computer vision syndrome. We'll have a discussion on that later. And also in patients with Parkinsonism. And when we are keen in reading or watching television also, we'll have that type of deficiencies. And drug action. So what are the drugs which causes dry eye? Diuretics, beta blockers, antihistamines, sedatives, anti-anxiety medications, analgesics, and also we have already told the topical medicines that we give also contains preservatives. These preservatives itself can result in dry eyes. And also patients who undergo chemotherapy, that is cancer patients usually dry eye complaints are and chemo drugs dry eye predispose drugs. Most commonly we see chemo drugs and also topical drugs. So what are the symptoms when the patient complains with dry eye? The patient complains of irritation, foreign body sensation, itching, and feeling of dryness. The signs, sometimes we'll get signs like a stringy mucus and particulate matter in tear film. Then there'll be conjunctival cirrhosis. A conjunctival glistening appearance it will be dry-like. And the cornea will be showing certain punctate epithelial erosions. And in severe cases, there will be formation of filaments also on the cornea. So what are the common risk factors which predispose to dry eye disorders? One is age. As age increases, there is a chance for more dry eye disorders. Gender, female or males are more common in females. Why? Because due to the hormone changes. That is during menopause and also in patients who are taking hormone replacement therapy, especially if they're not taking progesterone. Estrogen is the one which is mainly responsible. If they're taking only estrogen, then they are more prone to develop dry eye disorders. So when there is menopause also due to these hormonal changes, again, there is chance. Then smoking, autoimmune disorders, we have already mentioned certain autoimmune disorders like Sjogren's syndrome, contact lens wearers, and also medications, and exposure and eyelid oblonging disorders and other environmental factors. So what are the tests that we do for tear film to detect any tear film deficiency? This is important for you because a Schirmer strip is usually kept as an OSCE for you. So the main three important tests that we do is, one is tear film breakup time. Tear film breakup time. The second one is Schirmer's test. Third one is Roll's Bengal Whiter stain. So if any two of these are positive, we can say that dry eye syndrome is being diagnosed. And also the other test, we can measure the tear level of lysozyme and lactoferrin, which are components of tear film. And also we can measure the tear osmolarity. So these are really the first three tests are important for you. So one is tear film breakup time. What is tear film breakup time? How do we do that? And this is how it is being done. We stain the patient with a fluorescent strip. You can see in this figure. Stain and examine under cobalt blue light filter. And we ask the patient to completely blink the eye and then open. And then we have to look under the slit lamp for appearance of the first dry spot. So the interval between the complete blinking and appearance of the first dry spot, that time should be noted. So this is an indicator of adequacy of mucin content of the tears. This is the innermost layer. So the interval between a complete blink and appearance of the first dry spot on cornea. How do we do it? Instill a drop of fluorescent, examine cobalt blue light. And what is the normal time? That is for the first dry spot to appear on cornea, the normal time is 15 to 35 seconds. If the dry spot appears earlier, means the tear film is unstable. So if it is less than 10 seconds, the tear film is unstable. It's the same thing. Okay, and then we have the Schirmer's test. Schirmer's test, actually, we have two types of Schirmer's test. One is first Schirmer test 1 and Schirmer's test 2. Schirmer's test 1 means it is done without anesthesia. So with anesthesia means we are abolishing the reflex secretion. So without anesthesia means it measures the total tear secretion. That is in the initial slides I have mentioned about two types of secretion, now basal as well as reflex secretion. So without anesthesia means we can measure these two types of secretion, basal as well as the resting secretion as well as the reflex secretion. But with anesthesia, it measures only the basal secretion because the reflex secretion is being abolished. So, Schirmer strip എല്ലാവരും കണ്ടിട്ടുണ്ടാവുമല്ലോ അല്ലേ? ഇത് ഇങ്ങനത്തെ ഒരു വൈറ്റ് സ്ട്രിപ്പ് ആണ്. അതിൽ കുറെ മാർക്കിങ്സ് കാണാം. And the markings is usually ഇങ്ങനെ കുറെ ലൈൻസ് ആയിട്ട് കാണാൻ പറ്റും. It is from 5 mm to 35 mm വരെയാണ് അതിന്റെ റീഡിങ് പോകുന്നത്. So, a paper actually ഒരു പേരുണ്ട്. It is known as Wortmann 41 filter paper. So it is 5 to 35 mm strip of Wortmann 41 filter paper. How do we place it? Actually, it is folded 5 millimeter from one edge, and it is kept in the lower fornix at the junction of medial 2/3 and the lower lateral 1/3 of the eyelid. നമ്മളിങ്ങനെ വെക്കുന്നത് medial 2/3 lateral 1/3 ഇടയിലായിട്ട് 5 mm fold ചെയ്ത് അകത്തേക്ക് വെച്ചേക്കും. So you can see that the strip is getting wetted അല്ലെ, ഇങ്ങനെ വെറ്റ് ചെയ്ത് വരും. അങ്ങനെയാണ് നമ്മൾ അതിനെ മെഷർ ചെയ്യുന്നത്. അതായത് പേഷ്യന്റിനോട് ബ്ലിങ്ക് ചെയ്യാൻ പാടില്ല എന്ന് പറയണം. ആൻഡ് ഓൾസോ ദേ ഷുഡ് ബി ലുക്കിംഗ് അപ്പ്, ഷുഡ് നോട്ട് ക്ലോസ് ദ ഐസ്. ആൻഡ് ആഫ്റ്റർ 5 minutes ആണ് നമ്മൾ റീഡ് ചെയ്യുന്നത്. സോ വി മെഷർ വെറ്റിംഗ് എ ഫിൽറ്റർ പേപ്പർ സ്ട്രിപ്പ് ഫ്രം bent end. And normally it should be more than 15 millimeters. When the reading is more between 5 to 10 millimeters, we say there is mild to moderate keratoconjunctivitis sicca. And when it is less than 5 millimeters, we say it is severe keratoconjunctivitis sicca. So type 2 is actually to know the basal secretion of tears. അതായത് റെസ്റ്റിംഗ് ടൈമിൽ പേഷ്യന്റ് പ്രൊഡ്യൂസ് ചെയ്യുന്നുണ്ട്, അതോ റിഫ്ലെക്സ് ആയിട്ട് മാത്രമേ പ്രൊഡ്യൂസ് ചെയ്യുന്നുള്ളൂ. So we have to abolish the reflex secretion by using a topical anesthetic. So it is done with an anesthetic. And again, the normal value is 15 millimeter, and less than 5 millimeter indicates severe keratoconjunctivitis. This is another test. It's known as phenol red. That's not important for you actually. Here we have a thread which is impregnated with a pH sensitive dye. And actually we place it similar to the Schirmer strip, and it is measured after 15 seconds. So due to presence of dye, the color changes from yellow to red when there is flow of tears, and 6 mm is abnormal. And we have just know these names only, no need for knowing the details. Tear lysozyme assay means the measuring the amount of tear lysozyme. So it is actually of great diagnostic and prognostic value. Then lactoferrin radial immunodeficient assay. It's a major protein which is secreted by lacrimal glands, and it is decreased in Sjogren's syndrome and other lacrimal gland diseases. So again, we have available kits to measure these things. Then we have the fluorescent clearance test. This one actually we normally does. That is why what we do is actually we instill fluorescent on the ocular surface, and we measure the residual dye in Schirmer strip at interval of 1, 10, 20, and 30 minutes under blue light using fluorophotometry. So in normal eyes, the values will have fallen to 0 after 20 minutes. That means due to the tear normal flow of tears, the fluorescent will get cleared after 20 minutes. So the values will be fallen to 0 after 20 minutes. Okay, delay in clearance means there is a dry eye. Now this tear osmolarity also helps in measuring. No need to know these values and all. You can measure the tear osmolarity, also helps in diagnosing dry eye. Then conjunctival scraping, again it stains with Giemsa stain. In dry eyes, what we can see is numerous goblet cells, pink cytoplasm and nucleus on one side. Conjunctival scraping is of useful. So another important thing is conjunctival impression cytology. We can see that one paper is being kept there, then an impression is taken, and we see for any squamous metaplasia, conjunctival impression cytology. Similarly, cellulose acetate paper strips are applied near the limbus on the bulbar conjunctiva, kept for 3 to 5 seconds, then removed. And these are again dropped into fixative salts, stained with PAS and hematocillin, examined under microscope to look for the degree of squamous metaplasia. And depending on the findings, we grade it from 0 to 5. Not needed for you. Marginal tear strip characteristics is actually very normal. That is when we are make the patient sit under slit lamp and just see for a concave meniscus, which is formed by the tears between the eyelid margin and the inferior bulbar conjunctiva. Normally, there will be a height of 0.5 mm of tear strip. That is considered to be normal. If there is any discontinuity in this tear strip, or when there is an absence in tear strip, means again it is an important central. This is actually we do in routine clinical practice. Just നമുക്ക് patient slit lamp ഇരുത്തിയിട്ട് നമ്മുടെ lower lid marginന്റെയും bulbar conjunctiva അവിടെ ഒരു ലൈൻ പോലെ ഒരു ഇങ്ങനെ tear film നിൽക്കുന്ന കാണാൻ പറ്റും. അതുണ്ടോ ഇല്ലയോ എന്ന് നോക്കിയാൽ മതി. Severe dry eye, this will be absent. Then we have a tear phone test, that is tears when dried on slide shows ferning. So based on that characteristics, we can classify it into 4 groups. No need to know the details. Then another important one is fluorophotometry. It's more of a laboratory method, measures the thickness of the tear film. Fluorophotometry. All these you need to know the names only. Then another one important thing is the tear scope that can also be used to measure the or to know the dry eye factor. Again, no need to know the details of all this. This is important. Staining procedure, fluorescent staining. So we use fluorescent to stain conjunctiva and cornea. It shows areas of denuded corneal epithelium and punctate staining of cornea. So this is actually, you can see that the inferior part is stained with fluorescent. So it is actually typical for keratoconjunctivitis, sicca. So these are the patterns of stain that we commonly encounter. That is, when there is a superior limbic keratoconjunctivitis, we get a superior staining with of the cornea with the fluorescent. When there is interpalpebral staining, and nadukku matram aanu namukku staining varunennundengil, aqueous tear deficiency lana usually interpalpebral staining of cornea and conjunctiva is common in aqueous tear deficiency. Nadukatha bhagavayirikkum koodal stain cheyidikkunna. Superior conjunctiva and stain cheyidikkunnengil superior limbic keratoconjunctivitis lana usually കാണുന്നത്. ഇതിനകത്ത് നമുക്കിപ്പോൾ ഇൻഫീരിയർ ആണ് കാണുന്നത് അല്ലേ? ഇൻഫീരിയർ കോർണിയൽ ഇൻഫീരിയർ സ്റ്റെയിനിങ് ആണ് വരുന്നത്, കോർണിയൽ സ്റ്റെയിനിങ് ആണ് വരുന്നതെന്നുണ്ടെങ്കിൽ യൂഷ്വലി വി ഗെറ്റ് ഇൻ എന്തുവാണ് നമ്മുടെ താഴത്തെ ലിഡിന്റെ പ്രോബ്ലംസിലാണ്, ബ്ലിഫറൈറ്റിസ് അല്ലെങ്കിൽ എക്സ്പോഷർ കെരറ്റൈറ്റിസ് അങ്ങനത്തെ കണ്ടീഷൻസിലായിരിക്കും വരുന്നത്. അപ്പൊ ഇതാണ് പാറ്റേൺ യൂഷ്വലി നമ്മൾ കാണുന്നത്. ആക്ച്വലി ഒരു ഡിഫ്യൂസ് ആയിട്ടുള്ള പാറ്റേൺ നമുക്ക് ട്രോമാറ്റോക്സിറ്റി, വൈറൽ കൺജങ്ക്റ്റിവിറ്റിസ് കാണാൻ നോട്ട് ഇമ്പോർട്ടൻറ്റ്. Inferior actually we get in all trichiasis, lag of thalmos, blephoroconjunctivitis, all these things, blepharitis and other conditions. Interpalpebral is mainly in dry eye disease. That is aqueous tear film deficiency. Superior we get in superior limbic keratoconjunctivitis, or when there is a foreign body under the eyelid and the conditions. And then in contact lens virus we get staining at the 3 and 9 o'clock. So these are the important patterns. At least you have to mention inferior is seen in blepharitis and lag of thalmos, interpalpebral in dry eye disease, mainly aqueous tear deficiency, superior limbic pattern, superior limbic keratoconjunctivitis. These 3 are important. So rose Bengal staining, it's a derivative of fluorescent. The difference from that is actually it stains conjunctiva also. So affinity for dead and devitalized epithelial cells that have a lost or altered mucus layer, and stains it stains actually damaged conjunctiva and corneal epithelium, mucus threads and filaments, and they'll be seen as red color. The scoring system is not important for you. So these are the types of patterns of staining that we get in early, moderate and late phases. And this is rose Bengal staining. You can see that here we can have a typical for moderate keratoconjunctivitis. Conjunctiva stains more than the cornea, and the nasal conjunctiva stains more than the temporal conjunctiva. ഇവിടെ നമുക്ക് റെഡ് ആയിട്ട് കാണുന്നില്ല. അപ്പൊ ഇവിടെ നമുക്കത് കൂടുതൽ ഡ്രൈനെസ് ഉണ്ടെന്ന് പറയാൻ പറ്റും. കൺജങ്ക്റ്റൈവ കൂടുതൽ സ്റ്റെയിൻ ആവുന്ന റോസ് ബെംഗാൾ വെച്ചിട്ടാണ്. So false positive staining also can occur in conditions with chronic conjunctivitis, then acute chemical conjunctivitis. So in such conditions we need to be careful. Another type which is used for staining purposes, lissamine green. So important one is fluorescent that we use commonly. We also use rose Bengal and lissamine green. That's all. Pattern not needed. So what is the treatment? The treatment is actually, it is mainly a deficiency of the tear film. So how we treat is actually we supplement with tear substitutes. So we have artificial tear drops as well as ointments. Mainly we have methyl cellulose, hypromellose, polyvinyl alcohol type, or in conditions when there is a cell-mediated inflammation of the lacrimal tissue, when the artificial teardrops are not working, in order to reduce the cell-mediated inflammation, we give topical cyclosporin in a low dose, 0.05% or 0.1%. Also in conditions when there is a severe dryness conditions, like in Sjogren syndrome and like SJS, Stevens-Johnson syndrome and all, we can also go for topical retinoids to reverse the cellular changes or squamous metaplasia. So almost all are of aqueous substitutes. There are no mucus substitutes. The drops and gels that we prescribe are the cellulose derivatives. That is methyl cellulose, hypermellose, varieties. Then we have carbomers. Drops on cellulose derivatives under carbomers under polyvinyl alcohol under sodium hyaluronate under. So cellulose derivatives are usually prescribed in. Carbomers they adhere to ocular surface and so they are long lasting. Then carboxymethyl cellulose. Then polyvinyl alcohol actually mucin deficiency polyvinyl alcohol. It increases the persistence of tear film. Then sodium hyaluronate is injuries usually it promotes conjunctival and corneal healing. Usually patients morning corneal abrasion other healing conditions like we give sodium hyaluronate. And in very severe cases, we give autologous patient and blood autologous serum we give in very severe cases. Chemical injury cases like lubricants we go for autologous serum. Then we have ointments. Ointments are long lasting patient night time apply containing petrolatum mineral oil can be used at bedtime. And the preservative usually contains toxicity. Non-preservative drops when a patient prescribed. Then we have mucolytics. Then severe conditions like I told that there will be formation of mucus threads and filaments. Another condition in order to disperse the mucus threads and to disperse the filaments and reducing the tear viscosity, we can use acetylcysteine 5% drops. So that is a mucolytic. It decreases the tear viscosity. Then also another important thing is we have some amount of tears, we can preserve that existing tears. We can either substitute or we can preserve the existing tears. How can we preserve the existing tears? One, we can reduce the evaporation by decreasing the room temperature and using protective glasses, especially when the patient is working in an atmosphere having increased exposure to heat, or when the patient is continuously looking in the computer, we tell them to use anti-glare glasses like that. Protective glasses can be used. Then also we can go for punctal occlusion because the tears is being drained through the punctum. So punctal occlusion will decrease the drainage. How can we do this? Actually, either we can go for a temporary occlusion or we can go for a permanent occlusion. So temporary occlusion means we can use collagen implants or cyanacrylate glue like tissue adhesives, etc. can be used to occlude the punctum temporarily. And if it is not needed that we have to do a permanent punctal occlusion means then we can go for electrocautery. Cauterize the punctum closed tear preserve. Then certain type of lenses are also available which are being prescribed for moderately dry eyes, low water content HEMA lenses, then silicone rubber lenses, occlusive gas permeable lenses. Just know that there are water content lenses and gas permeable lenses, which also helps in maintaining some sort of treating dry eyes. Reduction of room temperature, room humidifiers, and tassoraphy. Then botulinum toxin, tassoraphy actually it is not prescribed as a treatment, mentioned as a treatment for dry eye. When do we do tassoraphy? Tassoraphy is mainly indicated when a complication due to dry eye occurs, as in exposure keratitis. When there's an exposure keratitis which is not responding to lubricants, we go for tassoraphy. We usually lateral tassoraphy or central tassoraphy. Upper lid and lower lid suture tear film then botulinum toxin injection actually severe dry eye, the patient will be complaining of a severe blepharospasm. Patient temporary measure we can go for botulinum toxin injection. Usually it is injected at the middle canthus. It reduces tear drainage, presumably by blocking the lid ligaments. And in Sjogren syndrome, symptoms are oral cholinergic agonist use like pilocarpine. And also we have to follow a healthy diet to avoid dry eye, which is important. It is rich in vitamin A, lutein, zeaxanthin, vitamin C, bioflavonoids, vitamin E, selenium, zinc, and fatty acids. So one word about the computer vision syndrome. This is the last slide. So computer vision syndrome actually commonly techies common condition. Online classes problem computer vision syndrome. Screen like time irritation, watering, blurring of vision, എന്നൊക്കെ പറഞ്ഞിട്ട് പേഷ്യന്റ് വരുന്നത്. So that is known as computer vision syndrome or a digital eye strain. It describes a group of eye and vision related problems that result from prolonged use of computer, tablet, e-reader and cell phone use. So how will we alleviate the digital eye strain? That is following a 20-20-20 rule. What is 20-20-20 rule? That means we have to take a 20-second break to view something which is 20 feet away every 20 minutes. നമ്മൾ യൂഷ്വലി കമ്പ്യൂട്ടറിൽ നോക്കിയതിനു ശേഷം സ്ട്രെയിൻ എന്ന് പറഞ്ഞ പേഷ്യൻസിനോട് പറയാറുണ്ട് നമ്മൾ ഒരു എല്ലാ 20 മിനിറ്റും ആ അതിൽ നിന്നൊന്ന് മാറ്റിയിട്ട് ദൂരെ ഒരു വസ്തുവിലേക്ക് ഫോക്കസ് ചെയ്തിട്ട് ഒരു 20 seconds ബ്രേക്ക് എടുക്കാൻ പറയും. വേറെ എന്തൊക്കെ പറഞ്ഞു കൊടുക്കാറുണ്ട്? We have to ask them to frequently blink the eyes and also do like eye exercises. So the most common symptoms associated with computer vision syndrome or digital eye strain are vision complaints of eye strain, headaches, blurring of vision, dry eyes. In a patient posture ശരിയല്ല എന്നുണ്ടെങ്കിൽ they'll complain of neck and shoulder pain. So these symptoms may be caused by poor lighting, a glare on a digital screen, improper viewing distances, poor seating posture, uncorrected vision problems, a combination of these factors. So how should be the location of the computer screen? The computer screen should be located 15 to 20 degrees below eye level as measured from the center of the screen. And it should be 20 to 28 inches from the eyes. This is the normal location of the computer screen. And lighting, it should be like the position of the computer screen should be positioned in such a way to avoid glare. Window and glare and light on the Then also the 20-20-20 rule. Rest breaks long periods of continuous strain every 20 minutes. The person who is examining should have a 20-second break. Then also we can say the patient to use anti-glare screens and blinking. Blinking in the tear film normal coating fully evaporation on blinking draining proper proper coating. So blinking is very important. Important condition, the computer vision syndrome. So these are the conditions. So extraocular patient on the posture problem and the patient problem symptoms, neck stiffness, neck pain, shoulder pain, headache, backache. Ocular surface patient will complain of tearing, gritty sensation, then dryness, redness, burning sensation, and contact lens related problem. നമ്മൾ ഒത്തിരി ഒരു നിയർ സാധനത്തിലോട്ട് ഫോക്കസ് ചെയ്യുമ്പോൾ എന്താ പറ്റുന്നത്? നമ്മുടെ അക്കോമഡേറ്റീവ് മെക്കാനിസത്തിന് പ്രശ്നം വരുവാണ് അല്ലെ? സോ പേഷ്യന്റ് വിൽ കംപ്ലൈൻ ഓഫ് ബ്ലറിംഗ് ഓഫ് വിഷൻ. പക്ഷെ നമ്മൾ അവിടെ വന്ന് നോക്കുന്ന സമയത്ത് പേഷ്യന്റ് വിഷൻ വിൽ ബി 6/6, ഡബിൾ വിഷൻ, രണ്ടായിട്ട് കാണുന്നു എന്ന് പറയും. കാരണം ഒത്തിരി അക്കോമഡേഷൻ യൂസ് ചെയ്യുന്നതുകൊണ്ടാണ്. പ്രസ്ബയോപ്പിയ, മയോപ്പിയ ആൻഡ് സ്ലോനെസ് ഓഫ് ഫോക്കസ് ചേഞ്ച്. ഇതും യൂഷ്വലി നമ്മൾ കാണുന്നതിന് ഫോക്കസ് ചേഞ്ച് ചെയ്യുമ്പോൾ ഞാൻ കുറെ നേരം ഇതിൽ നോക്കിയിട്ട് അപ്പുറത്തേക്ക് നോക്കുമ്പോഴേക്കും എനിക്ക് ക്ലാരിറ്റി കിട്ടുന്നില്ല. ഇതെല്ലാം ആക്ച്വലി ഇതിന്റെ ഭാഗമായിട്ട് വരുന്നതാണ്. So personal factors again, poor seating posture, improper viewing distances, improper viewing angle, other ocular diseases in the patient. The age of the patient is important, whether he is having any other medical diseases. And the lighting, environmental factors like poor lighting, glare, the computer factor and then dry eyes secondary to decreased blink rate can be easily managed by applying lubricating eye drops or artificial tears. Blinking patient blink and also we can supplement them with lubricating eye drops. Then frequent short break can restore and relax the accommodative system of the eyes and preventing ocular strain and visual fatigue. We already 20-20-20 rule. That is another management. Then modification in the ergonomics of the working environment, patient education, and proper eye care are important strategies in preventing computer vision syndrome. So the theory topic just go through this topic. Just just at least 3 layers of the tear film അതിൽ എവിടെന്നാ പ്രൊഡ്യൂസ് ചെയ്യുന്നത്, ഓരോന്നിന്റെ ഫങ്ഷൻസ്, അപ്പൊ അതിന്റെ ഡെഫിഷ്യൻസി വരുമ്പോൾ എന്ത് കൊണ്ട് ഡെഫിഷ്യൻസി വരും. ആൻഡ് ടിയർ ഫിലിം ഹൗ വിൽ ബി ട്രീറ്റ്മെന്റ് ഇമ്പോർട്ടന്റ് ആയിട്ട് ലൂബ്രിക്കൻസ് തന്നെയാണ് നമ്മൾ മെയിൻലി പറയുന്നത്. പിന്നെ പങ്ക്ച്വൽ ഒക്ലൂഷൻസും ലെൻസസും ബാക്കി അല്ലാതെ യൂട്ടാസോഗ്രാഫി ബോട്ടുലിനം ടോക്സ് ഒന്നും പറഞ്ഞില്ലെങ്കിലും കുഴപ്പമില്ല, മറ്റു കാര്യങ്ങളെങ്കിലും ഇമ്പോർട്ടന്റ് ആയിട്ട് പറയാം. ആൻഡ് ടിയർ ഫിലിം ടെസ്റ്റ് ഇസ് ഇമ്പോർട്ടന്റ് ഫോർ യു. അതിനകത്ത് മെയിനായിട്ട് ഷോമേഴ്സ് ടെസ്റ്റും ടിയർ ബ്രേക്കപ്പ് ടൈമും ഫ്ലൂറസെൻസ് സ്റ്റെയിനിങ്, ഇത്രയും കാര്യങ്ങൾ അറിഞ്ഞാൽ മതി. ഓൺലി ഒരു തിയറി ടോപ്പിക് ആണ്. എന്തെങ്കിലും ഡൗട്ട് ഉണ്ടോ? സുധീൽ
ആ മാം. ഇല്ല മാം.
എന്തെങ്കിലും ഡൗട്ട്സ് വല്ലതും ഉണ്ടോ?
ഇല്ല മാം.
ഓക്കെ. അപ്പോ എനിക്ക് ഇത് അയച്ചു തരണം. അറ്റൻഡൻസ് ആരാ അയക്കുന്ന? ലിയാണോ?
ഇല്ല മാം, ഞാൻ സ്ക്രീൻഷോട്ട് എടുത്തിട്ടുണ്ട്, അയക്കാം മാം.
ഓക്കെ ഓക്കെ ഫൈൻ. വേറെ ഡൗട്ട്സ് ഒന്നും ഇല്ലല്ലോ? അതിൻ്റെ
ഇല്ല
ചെയ്യാമോ
മാം.
ക്ലാസ്?
ആ മാം.
ഓക്കെ ഫൈൻ.
താങ്ക് യു മാം.
ഓക്കെ.